but we'll keep the structure as is so we can keep on time. But I have no problem getting a little spontaneous and go off script. Okay.
I think, Eric, what I've enjoyed this is a conversation, at least.
Hello, everyone, and welcome back to Bright Spots in Healthcare. This is Eric Glazer, your host. I am actually unusually not in my regular studio today. So those of you watching via webinar, you see me with a headset on. I think we will be, we'll get through this, but we're gonna, first episode in quite some time where I'm not in our regular studio. We had a last minute substitution to our show today in our guest list. I'm gonna mention that in just a moment. For those joining us for the first time, Bright Spots in Healthcare is produced by Shared Purpose Connect, my organization. We bring leaders together not only to inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. Because we believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Now, if you have not subscribed to Bright Spots in Healthcare in your podcast app, you could do it right now. You're definitely multitasking, I could tell. Why don't you grab your tablet, grab your phone, type in Bright Spots in Healthcare, click subscribe. Every episode will be downloaded to your tablet or to your phone, wherever you listen to shows, Amazon, Apple, Google Play, anywhere you listen to shows, you will find this podcast. Tons of great information from leaders around the country, providing you ideas and bright spots. So I ask you the favor of clicking right now and subscribing. Today's episode is supported by our friends at Socially Determined. If you don't know who they are an industry leader in social risk analytics and solutions. I would argue the industry leader, and they help health plans. And right now, our health plan's secret weapon in helping close the gap around redetermination that we're all grappling with around the industry. And that's a perfectly into our topic, that disenrollment tsunami, how to enhance your Medicaid redetermination plan. We have a great discussion planned for you and a tremendous panel in front of you, 3 incredible experts. We have a little bit of a substitution. Ashley Perry, a regular guest on the show, had to step out unexpectedly. We have brought in her boss, Dr. Trenor Williams, the CEO and founder of Socially Determined. Maybe not up to Ashley's standard, but he will be a good close second. Trenor, thanks for coming in last minute. We have prepped him. He is ready to go. So you don't have any worries if you're listening on some of the information you are going to hear today. Also, we should have a couple of minutes for Q&A. You regulars know we often don't. This is an important topic. We know there's going to be some questions that come up. We've allotted some time for questions and answers. So if you want to help me moderate, there's a Q&A module, as all of you know, within your Zoom application at the bottom of your screen. Use that to submit questions. Sherry Kills, one of my producers, as well as one of our, we have Chris Talley from Socially Determined, guest producing. We're going to moderate those questions. We're going to prioritize them and integrate them into the flow of the conversation, because God knows I need help moderating. So please help me do that. Let's get started. And Trenor, I'd love to start with you just so we could really level set and frame out the problem. How big of a problem is Medicaid redetermination right now for our industry as we sit here today on July 20th, 2023?
Yeah, Eric, first of all, thank you. I'm glad I was able to step in. I may be Ashley's boss from a CEO standpoint, but I actually think Ashley is my boss, is really how it works. And I'm excited to have this conversation, especially with Millie and Darrel, 2 experts, right, who are living this every single day. And I'd be interested in the perspective as we get into it, because as little over 3 million individuals have already lost coverage since April in 33 states. And that's everything from 82%, Eric, in Texas to roughly 10% in Michigan. It feels like in the conversations that we're having around the country, what we're seeing and what you're seeing in reports, it's already bigger and happening faster than what we were predicting. Like if you go back and look at what Kaiser Family Foundation put out before redetermination started in April and some of the estimations, again, I think the speed and the initial numbers I think one of the interesting examples, like just Arkansas, I was on with some of the plans there recently, and April 1st, 50,000 lives, members lost coverage immediately as part of that process. They believe that roughly 80% of those folks were likely still eligible, and about half of that group were children. And again, you think about the impact that we're going to have, the gaps, right, in care that are getting created as part of that. Again, feels like it's happening. What's interesting too, and folks may have seen the recent article in CMS talking about actually pausing redetermination in certain states because of violations they believe that were happening. And it's going to be interesting. And the states, as far as I know, have not yet been named. But I think it's going to be really interesting where CMS, because they believe it is happening faster than anticipated, and more things could and should be done to be able to address those gaps, where they and when they start to lean in around the topic.
It's great setting the stage. And by the way, you reminded me that I dropped the ball on really giving a prelude to our other folks around the roundtable. So you're going to hear from Millie Menos, Director of Medicaid Product Administration at Horizon Blue Cross Blue Shield of New Jersey. And you're also going to hear from Darrel. He is the Vice President of Communications and Marketing at HealthNet, as many of you know, is a subsidiary of Centene. We're not going to give them their full bios, but we are going to put them both in the show description on your podcast app, and if you're watching live, within the chat of the Zoom, so you could get to know the three experts in front of you a little bit better. Millie, I want to bring you into the conversation next and talk about tactics, right? How are we attacking this issue now? Let's focus on approaches that are working here, and what is working right now at Horizon around maybe peer-to-peer training, and what's the impact that you see?
Sure. I think that Trenor set the stage really well about the wide scope that this is encompassing, how many stakeholders are involved in that process. And that's really where I want to go with what I'll say right now, which is it's not just the plans, right? There are so many stakeholders involved in this process. You have providers, you have community organizations. All of these folks are touch points for our Medicaid members, and they are involved in the outreach as well, right? It's all plans have robust community outreach, but it's the community centers, it is the providers' offices, the FQHCs that are in these neighborhoods day in and day out. They are an active part of the process, but they don't live, breathe Medicaid like the plans do, right? So they need our help. And that's what we've established. We are implementing a train the trainer model. And that is actually from direct feedback from our community partners. They're saying, we are getting questions every day. People are coming in. They want to know what is happening with Medicaid. How do I keep my Medicaid coverage? This is a confusing process, and we want to be able to help them. So as much as we would love to be able to blanket the state or states with our resources, we know that resources are limited, but by training the trainers and having a deeper understanding by those stakeholders of the Medicaid application, the renewal process, we can really expand our bandwidth.
Is there a profile of these trainers that, like, is it a Medicaid member? Is it someone that's at the CBO or another partner organization that is just closer to the member on a regular basis?
Yeah, I'd say it's folks who are interacting in care situations with members, and care can take a lot of meanings. So that could be someone who is in social services, helping someone who is going through substance use disorder. It could be someone working in an FQHC at the front desk who is scheduling a series of care, right? We don't want to see anyone lose coverage, especially folks that are in series of care, right, that are going to need ongoing treatment. So those folks have a real stake in making sure that people stay covered. Okay.
One last follow-up here. So I know that, like, sort of the learning and development functionality, the ability to sort of effectively franchise that knowledge to multiple people is a really hard thing to do well. How is Horizon, like, what's your approach to sort of training the initial trainer so they could be training the trainer, right? How are you rolling that out? Do you have a large department? Are you using, like, just so the folks can understand if they want to implement something like this?
Sure. So we utilize our community outreach team, and they put people, through school, through class. We have a really standardized curriculum where we tier it based on folks' interest level. We know that not everyone needs the full deep dive on every nitty-gritty part of Medicaid. So if you just want to understand what unwinding is and what the current lay of the land and the need to renew now that wasn't present for the last 3 years, we'll take you through that process just so you can answer some baseline questions when people walk through your door. If you want to go a little bit deeper, we have more detailed training on the specific parts of the state Medicaid application, where we'll take you through how to access it online, how to help someone create an account, how to really help them fill it out, and what each of those fields mean. So based on folks, ability and interest and time, we tailor it to them.
Okay, so communications and outreach standardizes the curriculum around unwinding. They tailor it based upon the type of organization and the educational level or needs of that particular organization. And the key is you're training folks who are interacting with members in care situations. Doesn't have to be clinical care, just care situations. So, and I could see that being especially effective just the closer you get to the day-to-day, the local and the community. Built inherently is a more trustworthy kind of rapport than if you're calling, the ivory tower or health plan on the phone about something. And so when we talk about trust and we talk about the different organizations that Millie just referenced, I'm going to bring in now Darrel Ang. He's the, again, VP of Communications and Marketing at HealthNet, and he might have just been assigned a whole project by Millie here from New Jersey. But, Darrel, how is HealthNet thinking about building trust with members, and what's your strategy in sort of driving Medicaid enrollment through building relationships or managing relationships with trusted partners in the community?
So first of all, thank you for having me. It's an honor to be here, and it's such an important topic for us all to talk about. So I appreciate the spotlight on this. We know that in healthcare, I think the last person you want to hear from is probably your insurance company. And maybe the second last person you want to hear from is the government telling you something to do about your health. So we're cognizant of that. And we had to know that we needed to build other voices into the ecosystem to make sure that we provided messages that people wanted to hear or would hear. So the one thing that didn't happen was this wasn't a surprise. We knew this was coming. And we may not have known the timing, but there was no question that at some point COVID was going to end and continuous coverage would no longer be the law of the land. It would have to go back to some sort of redetermination. So we started work on this last year. We knew that the words would be the same, the tactics would be the same, the date would be different, and perhaps some of the details on how it happened. So we knew that before engaging our community partners, we'd have to build materials for them and get them approved by our state regulator, because they appropriately want to make sure that what we're saying is in line with what the state says. So we started that work last year, and we put together toolkits and a campaign around it. We called it Review to Renew. And the reason why we put a campaign around it is internally, it helps focus people on a larger challenge, right? And, we can all say, patient safety is important, but until you put a campaign around it, it gets harder for people to focus on. So with this Review to Renew campaign, we also were able to focus our external parties, the media, et cetera, to join us on this campaign to help inform people about the need to renew. And we try to use the term renew because redetermination is such a jargon term. I mean, I know people at our health plan don't live it daily, and I have to explain to them, redetermination means you have to renew your coverage. And like, oh, that all makes sense now. So, I went to public school, so I try to explain it to my fellow public school peers. So after we put the campaign around it, we had the toolkit, and the toolkit consisted of all the tools that a partner might need to execute something especially if this wasn't their area of expertise. You wouldn't expect a Boys and Girls Club, a church, a school to independently write copy that would be persuasive in an email to get people to take the correct steps to renew their coverage. So we put this all together. We put social media graphics together. We made it easy to co-brand. So all they would have to do is either drop their logo in, find the highlight, type in their name, and copy and paste and go. So with those tools, we started finding the trusted messengers that have worked in healthcare. And one of the things that I did in my recent past is that the state of California borrowed me to lead their COVID vaccine communication. So back in 2020, they said, "Hey, who wants to work for free and come work under state rules?" And I said, "I guess that's me." So we had a number of groups that we work with, so schools, faith-based organizations, providers, directly to I guess our members, but direct to consumer, and meeting people where they were. And I'll give a couple of quick examples of what we did in each of these. So for schools, for example, we know there are established pathways that students and their parents get communicated to. I have kids in public school, and I get emails from them every day about soccer camp and after school programs and school lunches and all of that. So our idea was to leverage that in any way that we could. So we worked with the LA County Office of Education, and we cooperated with our competitor in that market to co-brand toolkits to make sure that we sent it out. And we don't see this as a competitive issue. We see this as sort of an ethical, moral issue to keep as many people covered as possible. So us, LA Care, the County Office of Education sent these out to all the districts, and we're starting to see these materials out in the public. And LA Care is doing the same for us during the back to school timeframe, where they'll be putting their materials together, throwing our logo on it, and doing the same thing, because we know you have to hear it a couple of times. For the faith-based organizations, we've been working with Catholic churches, African American churches, to make sure that we reach many of these Medicaid populations. I think there's a reason why politicians go to African American churches during the election period, because they know how to reach their audience and how to make them act. I think this week, one of the Help in RVs is going to a community festival at the Jamaica Festival at an East LA Catholic church. Honestly, I don't know what the Jamaica Festival is, but it draws a crowd. So we will happily send our people there to talk about redetermination. With providers, I think we'll talk about it a little later, but we know they drive action, and we want to make sure we work with them. And on the direct to member part, some members, believe what we say. So we want to make sure that, they get it directly from the source. So before redetermination happens for them, we'll send them mail. And if we have their email, their text, and their phone number, we'll call them, text them, and email them and say, look out, your packet's coming. 45 days before they go in pen status, which means they'll lose their coverage, the state will give us a list of who's received these packets. So we will go through and, to the extent that we can, mail, email, text, and robocall them to say, you need to take action, or you may lose coverage, as of a certain date. And for those who don't redetermine, we'll mail, email, robocall, text, and we'll have a human call them. And we have up to 90 days to get them back on the rolls. But that's sort of what we see as our best possible way to reach these people every single time we have a touch point, to give them another message on it.
That is great, and it's consistent with a lot of things that folks do on a regular basis, but at another level. And it's interesting just how thoughtful and how specific it is for each kind of organization. Just a quick follow up for that, Darrel. What's the infrastructure that needs to be put in place to be able to pull that trusted messenger strategy off? Is it you guys in your department doing it? Is there an a department within your organization that's dedicated to doing it?
So to leverage these trusted relationships, they have to be long-standing and they have to be well-established. So what we've learned is we can't walk into a community organization and say, hey, here's a toolkit, please use it, and have them be enthusiastic. But when we engage with organizations regularly, thoughtfully, and continuously, they're the ones who are likely to use it. So we have a different department. We have a public affairs and external relations department that regularly does care and feeding of these organizations to make sure that we stay connected, that we hear their needs, we address their needs when we can, and that it becomes a reciprocal relationship.
It's great. I want to talk about how we prepare to make programs like the ones that Millie and Darrel just mentioned super effective, super successful. So before one executes any of those aforementioned tactics, you obviously need to have a very targeted, data-driven strategy. So Trenor, how are you thinking about risk when it comes to assessing the Medicaid population around redetermination?
Yeah, well, I'm going to hammer home on that. And Millie, you mentioned it before, precision. You also said, like everybody, we don't have unlimited resources, right? And Darrel, as you talked about some of those really specific intervention strategies, I think of, this is a team sport, right? And how many people on the team can we get? But what I think is interesting, and I'm going to start, Eric, maybe as we think about it with two numbers. The first number, and this is anybody who's a musical theater, this might hit home. This is a musical theater part of the show. The first number is 63. The second number is over 525,000. So 63. So the average adult in the United States spends 63 minutes with an MD, PA, NP in a given year. 63 minutes. They spend over 525,000 minutes outside of somebody's care. 63 minutes as a patient, 525,000 minutes as a person. So that's the Seasons of Love rent, in case anybody wanted to know, as part of that. But it highlights the fact that, again, we think because we understand the disease that somebody has, a condition, maybe where they've gone for care, that we understand their healthcare trajectory, right? We think about them. And the reality is that those 525,000 minutes, life, where people live, that information, especially as we're talking about, and I love, Darrel, as you said it, like renewal, not redetermination, like how do we get people to renew? Understanding the lives, right, that our members have, where they are, what drives them, what creates barriers and obstacles for their health are the same barriers and obstacles that get created, right, as their risk of not getting, of renewing, right, their Medicaid eligibility as part of that. So what we believe and what we know across the country, right, access to that data is possible to understand with precision an individual's risk related to transportation and access to healthcare, right? How far do people live from a pharmacy? How far do people live from a federally qualified healthcare center? Do they have access to a public transportation network? Do they have access to a car in the household for themselves? We know data around, again, if people live alone, they are less likely to renew, right? Men less likely than women to renew as part of that, as women make the majority of decisions around healthcare, right, in this country as part of that. When we look at risk related to financial strain, working multiple jobs, access to that information at a precise level, understanding, again, multiple factors, and being able to characterize an entire member population, and then with precision. And I think this is the key. Not everybody's the same, and I can't do everything for again, universally for 100% of the members that I have. So being able to use data to identify the people at highest risk of not renewing, of not redetermining, right? As it relates to language, health literacy, access, transportation, financial strain, that information in a precise way, being able to both look at the person and then being able to roll that up into a cohort of individuals that have the greatest risk, so that those strategies that Darrel talked about and Millie talked about, like I can get precise at a strategic level, where do I place the biggest bets? And I think when we look at organizations like Horizon, like HealthNet, right, who are making inroads in populations as part of that, it's a data-driven, it is a precise set of activities that allow you to get the most value from those interventions.
And so if you're a health plan thinking through the strategy and understanding, like, could we pull this off? What are some, like, I mean, what are the three things they need to be looking at or asking? Like, I guess the first would probably be like, can they actually reach that member, right?
So I would love for Millie and Darrel, and hopefully they figured out, I think one of the surprising things that we see is the number of members health plan may not have updated contact information on as part of that, right? So I think that's, you would think that, of course, you know exactly where everybody is and how to reach them, but people, again, whether they're changing their phones, email addresses, right? They've moved and haven't let the plan know, right? Maybe their job knows because they're getting a paycheck as part of that. So just understanding that. Second piece is, I think about language, right? And message and messenger as part of that, and understanding, again, somebody's preferred language, their preferred way that they want to be reached out to. Just those factors alone, I think, are incredibly important. And then how they have accessed healthcare as part of that, as you start to think about the resources available to them, whether that's primary care in a federally qualified healthcare center, enrolled in a specific program, again, care management or other things like that, being able to understand where you've had historic touch points with those individuals is really important as well.
That's great. I want, Darrel, what's your take on this? Like, how are you guys using data to drive redetermination?
So I want to underscore a point that Trenor made quickly. So, you know, you are right. We don't have good enough data on our members. I don't think that's specific to HealthNet or to any plan, right? Like when you think about where all of us were at the beginning of the pandemic, even non-Medicaid members, right? They moved away from city centers. You know, they, you know, all work remotely now. I assume they all live in Austin or Denver or somewhere, you know, much different than where they would live before. You know, and you know, when you add the challenges of being on Medicaid, you know, housing insecurity, you know, perhaps that, you know, you're changing your number so your abusive partner can't find you. Like there are so many reasons that they make rational choices that make it hard for us to reach them. And you know, it's our job to continue to dig deeper to find ways to contact our members. I think the other thing I'd want to build on too is, so we ran our strategies through our health equity officer. And one of the thoughts is like, hey, you guys are doing a great job trying to do the traditional health equity, you know, touch points. But the people that we also need to focus on are those with the high security, because while we hope that no eligible member loses coverage, you know, the person relies on us month after month for their medication. Like, let's make sure that we talk to these people already. So let's make sure that we break down the silos and, you know, insert messaging into, you know, the normal nurse care manager communications with them. So, you know, they can also do it, right? And who do they trust more at the health plan than the person who helps them, you know, every several months, every time a problem pops up. So, you know, that's a great point, and that's a great call out. Sort of in the more general sense, you know, I have this in my notes, and I know something that he said is we don't have unlimited resources, you know, and as a Medicaid plan, we have about 2.5 million members, and out of a little over 3 million members total. And, you know, we have to focus our resources. So we made the decision last year that probably most people would be doing their messaging in English because it's easier. So we thought, okay, like, so let's overweight our efforts in Spanish. So I'll take LA County as an example. So there are 500 zip codes in LA County, and there are nearly 10 million people. And, you know, I wish I had the budget to go, you know, advertise and reach out to people in all of these zip codes, but I do not. So we thought, okay, well, how do we narrow this down? And we played with the levers, and, you know, we ended up ending up with the median zip codes where the median income was 60,000 or less, and at least 40% Hispanic. And, you know, so that brought 500 down to about 100. So we're driving all of our activity into these zip codes and adjacent zip codes. We kind of know that, you know, people don't stay within their zip codes, but, you know, I don't think 90210 would be a good way for us to target. And if my, I don't know, CEO were driving through Brentwood and seeing all of our messaging, he'd probably ask me, why are we not focusing our spend better? So those are the school districts we're targeting, the community-based organizations, the providers, et cetera. You know, I think one good example is we're partnering with Dollar General in the zip codes that we're targeting. So that means signage in their stores. That means QR codes, the little coupons you get after you check out or on the back of the receipt. We're making sure we have redetermination information there, and we know we're not reaching only health net members, but again, we don't think that this is a rising tide situation and not I'm only trying to reach people who have our card in their wallet. So the next thing is we need a feedback loop, right? Is this working? And California being one of the later redetermination states, we started getting data on our members this month, and the state, as long as they do the same thing every month, will release their data statewide today. So we'll furiously be reloading that website like we just applied for college, and trying to figure out whether, how we're doing compared to competitors. And we want to be able to tell, is mail working? Is text working? Is, our robocalls working? Because if they don't work, I'm going to stop doing it. And we're going to find other things to do. And my hope is that, we'll at least be at parity in some of the zip codes where we're focusing our efforts, and, because you would expect them to do worse. And, we'll iterate because we still have 11 months left in California to do this. So let's, we want to make sure we're spending our money and our resources correctly.
Thanks for that, Darrel. I want to, I have a question coming up. Trenor, I'm going to bring you back in. Before I bring the question or pose the question, I just want to tell everyone quickly about Socially Determined. If you're a regular to this show, you've probably heard a little bit about them because they're a regular supporter of Bright Spots in Healthcare. They are leading the entire industry in transforming them around social risk analytics and solutions. And they have a platform called SocialScape. It's a SaaS platform that empowers health systems and plans and other risk-bearing organizations to better manage risk, improve outcomes, and advance equity at scale. You should Google them. They were recently named by Fierce Healthcare as one of the 15 most promising healthcare companies in the country. They work with health plans throughout the country. I don't know if I can name names, so I won't. They're headquartered down in Washington, D.C. But what I like, actually, despite all the press and all the noise they're making in the industry, they're just exceptionally insightful and smart. Those of you who've met Ashley Perry, Trenor Williams, the entire team, really smart, interesting folks to talk to. And so as we're thinking about this, situation we're in with redetermination, if you have questions, if you want to just pick their brain around how they're leveraging analytics and maybe just get some free advice from them, and you want to have a conversation, I'm going to set that up for you. So we're going to put a poll up, and if anyone wants an email introduction with Trenor or Ashley, I will personally do that for you guys and set something up in the next 4 to 8 weeks. Trenor, with that, I want to bring you back in and provide an example. Like, you talked a lot about leveraging data and the approach and precision. Can you provide an example of how this is being put into practice?
Yeah, and it really, I think, mirrors, Millie, what you and Darrel were talking about as well. But when we have the opportunity to partner with plans in general, but specifically around redetermination renewal, being able to create an individual social risk profile at a member level, and then being able, we actually developed a specific redetermination risk score itself. And so the plans that we're working with are then we stack rank 1 to, in this case, it was just a little bit over 100,000 members that were part of it, of somebody's likelihood not to be able to renew. And again, going back to thinking about the drivers of that risk related to language, health literacy, age, access as part of that. As those organizations, getting back to what we've all said about the limited number of resources, specifically targeting from a language standpoint and from, Darrel, what you talked about as well, same idea, at a geographic specific standpoint, being able to target subpopulations. So being able to take 100,000, narrow that to the highest risk 20,000 individuals as part of that, and then specifically from a messaging, targeted communication and outreach, using omni-channel type messaging as part of that. So multiple different ways at a geographic level, and then starting with partners as well, and starting to pull in organizations both at a community level and some of their other intervention partners, and using those individuals to be able to do direct outreach and education and support Millie, what you talked about with the Train the Trainer program, not as sophisticated. So I'm going to make sure to follow up with the organization in terms of how they're able to do that. And so it'll be interesting to see, I think, over time. I know we're going to talk probably, Eric, about sort of what happens when people fall off, right? And become unenrolled as part of that. And what do you do? So I think over time, how do we, like Darrel said, measure on a regular basis the effectiveness, success, and then the continued evolution of those strategies.
Thanks. And Millie, like, how does this all resonate with you? And maybe offer up a little bit about your approach about how you're meeting members where they are.
Yeah, absolutely. I think the first thing to underscore is that we're talking about this now because the volume of members that are being affected makes it highly visible. But this is not a new situation. So when we think about pre-COVID, there was a regular member churn. People would get Medicaid coverage, their time for renewal would be up, they would have difficulty, and there would be plenty of barriers in them completing the renewal paperwork, and their coverage would be dropped. They may or may not have realized that. One of the big reasons, Darrel talked about this before, is the accuracy of contact information. That renewal paperwork may not have gotten to their home. They may not have understood it. English might not be their first language. Spanish might not be their first language, right? So there are a number of barriers that always existed. And so I think that, going forward, when we have this intense focus, right, that is really putting a lot of sunshine on an issue that has been present for a really long time, we're here to think about how can we do this better, right? In this post-COVID world, how can we help folks not fall into these coverage gaps that they often only realize they're in when they need care? That's actually when most people realize that their coverage has expired. Or they've been disenrolled, is when they end up in the emergency room at their most vulnerable time, which is horrible. So I think that the concept of meeting people where they are and understanding how much they know about the process, how much access they have to the Medicaid renewal process is the first and most important step. So part of that comes with an understanding that for the last 3 years, they didn't have to renew, and there was no disenrollment as a consequence if no renewal paperwork was sent in. And a lot of our members, right, at our plan, about 30% of our members, in fact, it's their very first time on Medicaid. So it is really important that that baseline education is given. 3 years is a very long time. Who knows, what we were all doing 3 years ago. I think actually we were probably in lockdown, but our lives have changed, dramatically since then. The gentlemen here have talked about that a lot of people have moved. Maybe they've moved in with other family members. Maybe, they've gone to a completely different place and had their lives upended, right, by COVID, as so many people have. So understanding that, and knowing that so many people are brand new to Medicaid and thus brand new to the renewal process, I think is first and foremost. Secondly, understanding that Medicaid members have really complicated lives. I think someone said at the top, right, health insurance and paperwork is not at the top of anyone's list, right? You're thinking about, how am I going to get food on the table? How am I going to keep the lights on? How am I going to pay rent? This process that hasn't affected you for the last 3 years, like it's not on your radar. So I think there's a lot of myth busting that needs to take place. I think there's a lot of education about what the process is. And then, thirdly, there's a lot of people that may not have the resources to complete the process. We know that a lot of our brick and mortar county board of social services have either been shut down or had their hours severely limited. So for folks who have issues with literacy, right, completing an application may be a real challenge. And those folks who they may have relied on previously at the offices to help walk them through that, that appointment is more difficult to get now. So one of the things that we've done to address this is starting with not jumping to the application, but talking to people about what their lives are and what their level and access to resources are. So the first thing we do is say, hi, we have a laptop here, we're going to navigate to the state website. Do you have a mobile phone? Oh, you do have a mobile phone. Almost everyone has a mobile phone. Even if you don't have a computer, most people have a mobile phone. And through the federal programs, a lot of people have smartphones, right? So access to the internet. So we show them where the state website is, where the application is. We pull it up, and we start. The very first question we ask is, do you have an email address? If the answer is no, that is our first step. So we create them an email address. I think in today's day and age in healthcare, although Medicaid is maybe last in all of our health insurance lines of business, it is moving to be more and more digital daily, right? You have your lab results sent digitally. Your follow-up appointment following discharge from the hospital may be virtual now. There are a number of things that come in via email from a variety of services that you access. And so having an email address, first of all, is free. And if we can help walk people through and not make any assumptions about where they are, but really meet them where they are and what they need to know to really take the process into their own hands, it's helpful, because we know that we can't be everywhere at once, right? Going back to the resource issue, which Darrel and Trenor, have really underscored. We know that if we can teach people, right, how to access their own application, it will enable them to be able to follow the status of it as they go through, because it's not only people missing the opportunity to send in their applications, it's also people who are getting caught up in the application process and having incomplete applications, right? An incomplete application does you just as much as a missing application, right? It does not get you coverage at the end of the day. So a lot of times people get caught up in that extra paperwork that they may need to send in following the initial application. So being able to track the status of it is really helpful. Being able to open up the world to them, right, on having digital access through email gets you the other piece of the puzzle too.
Trenor, you want to jump in? Trenor, just for a second. Sherry, why don't we do this? Well, Trenor's going to jump in, and then I want to take a question from our audience. While we do that, we have another tremendous episode next week on how AI is changing the member journey. We're going to talk about AI, machine learning, generative AI. There's going to be some great examples. Intermountain Health, UNC Health, and Geisinger is going to be they're going to be on the show. So if you want to register for that and not have to fill out the form again, and you just want Sherry to do it for you, we're going to put up a poll, and you're going to be able to just click yes and have Sherry do all the hard work for you. Thanks, Sherry, in advance. Trenor, go ahead. You wanted to jump in on and respond.
Well, I was just going to ask Millie and Darrel a question. Millie, as you all are capturing some of that contact information and or helping create, right, a contact vehicle through like a new email address. I guess the question for both of you, are you capturing preferred method of contact? So how does the member want to be outreach to via phone, call, text, or email, and then how your strategies from a communication then are tailored tied to that preferred method?
Yeah, so all of that contact information is gathered at the point of contact with the member. But I have to say, we're talking about 50 states here, each with their own very unique redetermination processes and operations. And so in some states, the process is very tightly prescribed and controlled by the state. In others, you may have that latitude. So I don't want to speak for all states there.
No, I just meant for you all, are you all then doing like preferred, like this member wants their communication, their primary to be email, right? Or this one wants, this member, I want to be able to reach out by my health plan via text. And I was just wondering, like, if then you're developing very specific strategies, again, sort of grouping those people by preferred method of contact and things like that.
I would say, I think there's I don't know, people joke about how health plans are run by punch cards and COBOL, and we're lucky that the Y2K bug didn't take us down. And I know that this is a capability that is being built, but we are not as advanced as many of our consumer-facing peers are in the healthcare industry. So we recognize this as an opportunity for us.
Hey, Darrel, I'm gonna actually ask all three of you, but sort of Darrel and Millie. What opportunities, and this is, by the way, A great question. I can't take credit for it. Hats off to Teresa. So what opportunities does the renewal process here present for just overall innovation and changes in doing things moving forward, like auto renewals for those that we already know their income eligibility? How are we going to be able to innovate and simplify the renewal options once we get through all of this, just learning the hard way?
Yeah, the introduction of ex parte renewals, which, to try and not use so much jargon, but that those auto renewals, right? We know that if people access other social services, for example, food support, their information and their level of income is recorded, right? There's labor and wage databases that are kept at the state level as well. So tapping into those and being able to verify income, and if the income checks out, it shouldn't matter if the paperwork is sent in, right? That's the concept of an ex parte renewal. The introduction and the higher use of those, I think, is a real game changer. And I think it's really exciting, and it's a great move for the Medicaid program as a whole moving forward.
In California, our Medicaid system is on a county by county basis, which means we have the opportunity to work with many, many different partners and the many, many different ways they do things. One of the things that the redetermination process is presenting is the ability to build new data pathways between us and counties. So, for example, prior to redetermination, a member would call us and say, hey, I have a new phone number. We would say, great. And then we would type into our system, and they would say, please call the county. Because what would happen is the next month they would send us a new file and it would overwrite our system. So even if you called us and told us your new information, it didn't matter unless you told the county. So because of redetermination, we're building these two-way pathways where we can now send updates to the counties and they can update their systems, or we can access the national postal change of address system. So, I think these seem basic, and I'm sure that mail order companies had figured this out a long time ago, but this is the sort of modernizing of the process that we're taking advantage of now to do, because was it Zeke Emanuel who said, don't ever let a good crisis go to waste? Let's take every opportunity we have to make these improvements while we can and while the focus and the resources are there.
Have you another question from our audience? I love how they were sort of our audience. I'm going to give you some constructive criticism. You wait for 45 minutes, and now I'm trying to jam in all your questions in the last 15 minutes, but they're all good questions, so hats off. So have you encountered any lags in the verification systems for updating redetermination information? I know some organizations are seeing members, they send the renewal letter, their status isn't updated for a couple of weeks later.
I've seen anecdotally that, many counties have the same staffing challenges that the rest of the economy has. So they have a tough time hiring and retaining their staff. In general, we think that it takes, 5 or 6 days after the end of the month, at least, to know what happened the previous month, because we get daily files. We'll get calls from reporters that say, hey, today's the last day of the month. What does your month look like? And that's like asking us, what the score of a baseball game is in the 7th inning, because the last 2 inning results haven't come in yet. So, we hear anecdotal evidence that, in some places the lag is a little longer. But, I guess I view this as, they're very smart people at the county and state level who are working on this. And, we will do our best with what we can get. And, we're, that is sort of out of our control.
I think the other thing to understand is that although disenrollment may occur, it is not actually the end of the road, right? So Medicaid members have the opportunity to a fair hearing, which is an appeal process. If you are disenrolled because of a procedural termination, meaning you did not send in your renewal paperwork, you have up to 90 days, and in some cases maybe longer, there are different circumstances, to send in that paperwork, and you will be retroactively, re-enrolled and covered. So that communication of the process, right? The outreach, it will not stop at the point of disenrollment, right? That education continues. And I think that if there are some lags at a specific county level, there is always that opportunity to recapture the member.
Right. Trenor, when thinking about duals and those over 65, and you were talking a lot, we're talking a lot about precision. Any thoughts or any changes in the approach when targeting duals in your precision strategy?
Only that I'm gonna tap into Millie. I think it was you who were talking about the high acuity, and again, those individuals with significant other comorbidities and diseases and conditions as part of that, versus we may have multiple Medicaid members, right, that don't have a lot of touch points from a healthcare standpoint and aren't living with chronic diseases. Unfortunately, as we all age, but certainly that dual population is much more likely, Eric, to have multiple chronic diseases, to be on multiple medications as part of that. And so I think that there's an opportunity to look at disease acuity, right, and social risk together in a combined, precise way, again, that should be heavily weighted on that. Two, they are much more likely, right, to be going to some type of provider, whether that's, again, a federally qualified healthcare center or other setting as part of that, and leveraging those partners even more specifically in that dually eligible population probably makes the most sense. Last thing would be related to specific housing, again, in certain geographies, whether that's, again, senior living or other like that, right, that is specifically for lower income individuals, is a good place, again, from a targeting standpoint, being able to go support.
Let's do this, folks. I'm just looking with 8 minutes left. I want to, Darrel, touch on the provider because you mentioned them earlier when we were talking about trusted organizations. But since like Millie kind of opened up the door a bit, I want to cover one topic first. What we do when we know someone who loses the coverage, right? So there's some who are going to be still eligible for Medicaid. What do we do when they lose their coverage? What do organizations listening do when there's someone that's no longer eligible, but maybe they have another product for that individual, like an exchange product? So let's talk a little bit about that. Trenor, since you have the mic, I'll let you go first, and then I'll move it over to Millie, and then Darrel, maybe I'll unless there's something terribly new, I'm going to shift you over to the provider question, which I'll re-ask.
So I'll just go quick in the interest of time, but in the same way that you might look at the entire population, right, early in preventative ways, and Millie, just like you said, right, this is something that we've always been doing. It's just the volume is higher right now. I think there's a specific opportunity each month, right, as individuals get disenrolled, to specifically look at that population of individuals and think of that as a whole, right? And what are the characteristics of that population from a language, from an access to healthcare, but take an analytic view of that subset of the population. And maybe, again, when you looked at your entire population from a language standpoint, right, percentage and breakdowns between English, Spanish, and multiple other languages is one way. But now you look at the population that just got disenrolled. What's the characteristics of that population, and how does it specifically change your intervention strategy? Again, you may have a shift in language, a shift in access, a shift in age as part of that, a shift, again, in geography. And so that each month, as you think about that, how does the data help you evolve that strategy in a much more precise way?
Millie, do you want anything to add there?
Yeah, I think that, kind of going more to the exchange part of your question, there was always a very strong wall between any plan that had a Medicaid line of business and a qualified health plan, right? Oftentimes, many organizations have both under one roof, and there was always a very strong wall there. I think that's one of the post-COVID flexibilities that we've seen, right? The ability for those two lines of business to really partner together to ensure that there is no gap in coverage, that coverage is seamless. So there are two types of people that are going to be disenrolled: the folks who should well and truly stay on Medicaid because they are eligible, and the folks that are no longer eligible, right? So you've sent in your paperwork, it's been reviewed. Let's say you hit over the income thresholds, and now what's next for you, right? So having that line of communication open to a QHP, making sure that the access for the state exchange, whatever the situation may be in your state, is there. I think that is the next phase of communication. So it doesn't just end with your Medicaid coverage has terminated. It's your Medicaid coverage, will end on this date, and here are the other options available to you.
I know, and I even see some comments here in the Q&A from someone who looks like a provider for sure. Darrel, we touched upon providers briefly, but they have to, right? They have to be a core component to any successful consumer advocacy program or strategy, right? So how is HealthNet leveraging providers to drive better redetermination rates?
Yeah, so just like community-based organizations, we feel like maintaining good communications and relationships with the providers is vital to success, both in redetermination and just generally. So, one of our core tenets is to be easy to do business with, and we try to roll it into this. So, for example, we send posters to providers to put in their office, and the easy way to do it is you send them a tube and say, please post this, right? The version that we do is we'll find the vendor to put command strips on so that when the roll goes into the office assistant can ask, whoever's in charge, can we put this up? And then you peel it and you put it on. I suppose we could send somebody to go get to put alcohol on your wall to clean it for you. But, short of that, that's, we're doing everything we can to make it easy for them. We are creating custom content, right? If you are a provider and you want us to help you co-brand our materials, send us your logo. We will do it for you and send it back. So it's, we know they're busy, their priority appropriately is providing medical care. So what can we do to reduce the burden for office staff who we need to help implement this? We're also doing webinars on this so people understand what's going on. I mean, a lot of times, people will come to the office and say, what is this? Like, what's going on here? And it's the office staff that helps explain the process. So we hold webinars, English and Spanish. The first one we had 75 providers on, and we're doing another set next week because every time we do it, people keep coming. So, we know that keeping them involved and keeping them informed and making it easy for them is really the key to getting them on board to helping us with this process.
And what are you doing to make it just super easy for the providers once they have a Medicaid member that they're on the phone with or is in their office?
Well,
how are you making their job easier?
Yeah, one of the things that we've been able to do is we've been able to share with providers their specific patients that will redetermine in a specific month based on the information that we have. So every provider gets this information. We have trained our teams to train providers on how to pull this information down and use it. And our hope is that as they have people coming through the office, they will say, hey, reminder, 2 months from now, it'll be your turn to redetermine or your turn to renew. So again, we want to make it as easy for them as possible so they can give targeted information at the right time to the right patient.
Great. And folks, if we want to get more into the weeds or just cover this more extensively over the next few months around unwinding and redetermination in general, let me know. We send you a survey. You already have it in your inbox. I ask you the favor of taking a couple minutes to fill it out. I always say, and we can't do this show without that feedback. We produce this show for you. This is actually your show. I know you don't own it, but it's really, you dictate what we cover. So this is your chance to communicate with me and my production team and what content we cover and provide us feedback on how we can be better and produce a better show for you. So please take the time, 3 minutes, maybe less, to fill out that multiple choice feedback form in your inbox, and we will produce another episode or two on this topic if that's what you all want and need. I want to thank everyone for coming today. We don't take the hour you spend with us lightly. Thank you for trusting us, whether it's watching live right now via webinar or you're on a walk, a drive, you're in the airport listening to us. Thank you for trusting us with a part of your day. And a special thank you to Darrel, Millie, and Trenor for all the work you did to prepare for this and for your participation today. Really, really appreciate it. So we hope that some of the ideas shared today could be brought to your organization, or at least inspire thinking for you to enhance your organization's current approach to redetermination. Like I said, this is your Bright Spots in Healthcare podcast. Have a great rest of your day, everyone. Take care.